we talked about that transpulmonary pressure, which I had said that the higher the transpulmonary pressure, the greater you can inflate the lungs. Well, transpulmonary pressure is a component when we talk about compliance of the lungs. Compliance of the lungs refers to the extent of lung expansion per unit increase in transpulmonary pressure. So in other words, how much air can you get into the lungs for a given increase in transpulmonary pressure? Compliance, just like you saw in regards to vascular compliance, is still a change in volume over a change in pressure. So here we're talking about a change in air volume, and the change in pressure is the change in transpulmonary pressure. When you also talk about compliance of the lungs, it is inversely related to elasticity. Being elastic is a good thing for the lungs in regards to normal passive expiration. But you need to realize when you need to stretch out the lungs, you have to stretch out the elastic element. And the elastic element has a tendency to oppose stretch. What makes it elastic is its ability to return to its original shape, which is important when we talk about exhalation. But you got to remember that being elastic also tends to oppose stretch. So if you have two elastic bands, one's kind of a thin one, one's a little bit thicker. The ones that's thicker will be harder to stretch out. So I want you to kind of keep that in mind with something being elastic. If something's too elastic in regards to compliance of the lungs, it won't be very compliant. And we're going to be looking at a couple instances where you have a change in compliance and it has to do with either loss of elasticity or something that's too elastic. Now this picture shows you that relationship between transpulmonary pressure, which is on the bottom, which again is measured in centimeters of water, and changes in lung volume. I just want you to look at this the bottom line. This is showing you for a given increase in transpulmonary pressure how much of that percent of the total lung volume you're able to get. And when you look at the slope of this line, it gives you an idea about compliance. So for a given change in pressure, how much air did you get in the lungs? The steeper the slope, or I should say slope of this line, the more the compliant. If it's kind of flat, it's not very compliant. So I want you to kind of notice this line, that as lung volume becomes higher and higher and higher, the line starts to flatten out. So compliance does change with respiration. It actually declines as you get to higher lung volumes. So there's actually two things that explain why compliance starts to decline at the higher lung volumes. One is that you're stretching out that elastic element. As you stretch a rubber band, the greater you stretch it, the harder and harder it is to be able to get it even further and further stretched. So you're really stretching out the elastic element and it wants to go back to its original position. The other reason why compliance declines at the higher lung volumes is an important concept referred to as surface tension. So we're going to be looking at surface tension and its role in lung compliance. So two things that affect lung compliance. Our lung compliance depends on how distensible the lung tissue and the surrounding thoracic cage is, which would come from the structure, the components of the lung tissue in that thoracic cavity, which is elastin and collagen. These things would tend to oppose stretch. The surface tension, 2/3 of our lung compliance is based on surface tension, and it's the surface tension of the fluid lining the alveoli. So we are going to be looking at surface tension shortly, but I want to give you an example of something or a couple clinical conditions that affect lung compliance, and it has to do with something in changing the structure of the lung, changing the amount of elastin or collagen that you have in either the lung tissue or the thoracic wall. So two examples of lung compliance, not really two examples. First thing is something that would increase lung compliance. The second example, we're going to say things that decrease lung compliance. So let's look at the first one. Emphysema and aging can be associated with an increased lung compliance. So both are associated with loss of elastin fibers. As you get older, you tend to lose some elastic fibers in your lungs. Emphysema is associated with destruction of elastic fibers in the lungs. So here, these people have no problem getting air in their lungs because they've lost that some of the elastic element of the lungs, which remember opposes stretch. So no problem getting air in, but what's the problem? There is such a thing as being too compliant. With these guys, the problem is getting the air out. In order to get the air out, they are going to have to be more active. They're going to be hunching their rib cages over, really forcing air out. The lungs don't just automatically return to their original position because they've lost the elastic element. With these conditions like lordosis, kyphosis, scoliosis, these are musculoskeletal disorders that are associated with a decrease in lung compliance. Here, the issue is having to do with the thoracic wall. In order to expand the lungs out, you need to expand the thoracic cavity. Well, with these conditions, they have a hard time expanding out that thoracic cavity, so lung compliance will be diminished. In lung disorders that are classified as being restrictive lung disorders, such as following tuberculosis, in which people have some scar tissue in their lungs, or fibrotic lung diseases, like following asbestosis would be an example, where they have this fibrotic, it's fibrotic, or you could think about more scar tissue. It's going to be hard to stretch out the lungs, and they're going to always kind of want to stay in their original shape. So these are restrictive. We call them restrictive lung diseases. With restrictive lung diseases, the issue is be able to get air into the lungs. So both of these are, these lines are associated with decreased lung compliance. So these people have a problem getting air into the lungs. So with increased lung compliance, the problem is getting air out. Decreased, the problem is getting air into the lungs. So let's look at the concept of surface tension and how it can play a role in lung compliance, and then give you also a clinical example or clinical examples of things that may affect surface tension and therefore affect compliance. So surface tension of a liquid is a measure of the work required to increase its surface area by a certain amount. So if I have a little bit of water that I put on top of the tabletop, the water wants to kind of beat up and form droplets. So why does water do that? Why do you have, if you put water in a capillary tube, why do you have a meniscus form? Well, you notice that whenever you have a liquid-air interface, the molecules of liquid are more strongly attracted to each other than to the gas molecules. And it produces a state of tension at the liquid surface called surface tension. It draws liquids closer together and reduces their contact with something that's not similar to it, like the gas molecules, and it will resist any force to tend to increase the surface area of that liquid. So in our alveoli, we have a thin layer of fluid that lines the alveoli. And think about what would happen, or what happens is as the lung expands. As the lung expands, work has to be done to stretch out the elastic tissue, but also to increase the surface area of that fluid layer. So that surface tension increases the amount of work required to inhale because of that water surface tension, which decreases lung compliance, making it much harder to stretch out the lungs. But it creates another problem. The hydrogen bonding between adjacent water molecules tends to pull them together into a rounded droplet, which, as you exhale, these guys are going to want to associate with each other. It's going to pull the walls of the alveoli inward and then make them collapse. So if the fluid that lines our alveoli was pure water, your alveoli would collapse in between each breath, and then it would make it even harder and harder and harder to expand the lungs with each breath. But we know there's or you will know, that your alveoli are not lined with just pure water. The alveoli have a substance in it that will reduce surface tension, and that substance is called surfactant. So surfactant, or the term surfactant, is a kind of a merged term for surface acting or surface active agent, which acts as a biological detergent. The surfactant is produced by type 2 alveolar cells. The type 1 alveolar cells are your simple squamous epithelium of the alveoli. The type 2 cells produce surfactant, which begins about your 4th month in gestation, but it's not going to be fully functional to about 7 months or later. So the surfactant is actually a mixture of proteins and phospholipids, and the major component of surfactant is this phospholipid referred to as dipalmitoyl phosphatidylcholine. Phosphatidylcholine you'll also often hear referred to as being lecithin, Lecithin. You'll be hearing that term lecithin at a later date in Physio 2 when we discuss lecithin as a component of bile. But in this case, we're talking about pulmonary surfactant. In dipalmitoyl phosphatidylcholine, this is the structure here. You have a glycerol backbone. You got 2 palmitic acids. That's the dipalmitoyl, meaning 2. And this here is the phosphatidylcholine. Now you'll notice that the phosphatidylcholine is amphipathic. So amphipathic means that you have a polar end and a nonpolar end. Now, this is kind of your basic picture that you often see when people draw a phospholipid. You got your polar head, which is the lecithin here. That's the polar head. It wants to hang out with water. And the nonpolar tail, or tails, is composed of the palmitic acid. So if you have this in an air-liquid interface, the hydrophilic end, this polar end, is will be in the liquid phase, and the hydrophobic end, or the nonpolar tail, would be towards the gas phase. And what's going to happen is these polar heads are going to be interspersed in between the water molecules that line your alveoli, which would decrease the cohesiveness of water molecules and actually act as like a detergent. Think of how laundry detergents work. They reduce the attraction of water for water, allowing the water to interact with and pass through fabric. So when we talk about in your lungs, in the alveoli, if you look at this picture here in the blue, these are representing your polar heads of the surfactant. These guys are going to be decreasing the interaction or the tendency of each individual water molecule to bind to each other. So it's going to reduce surface tension. So I want you to kind of look at these up here at the top. The scenario here is 2 different size alveoli, because all the alveoli in your lungs are not the same size. So 2 different size alveoli, and we do not have any surfactant. So I want to show you another role of surfactant besides reducing surface tension. What you have here, you have a big bubble and your small bubble. So it's a large alveoli, small alveoli. What surfactant does is it reduces the surface tension. And this equation right here, they call it the law of Laplace. The law of Laplace is pressure is equal to 2 times the tension, surface tension, divided by the radius. So I have the number set up for you. So if you notice between the large bubble and the small bubble, the pressure required to keep a smaller air bubble open is greater. So what would happen if you, for example, did not have surfactant lining the airways? You just say finished exhaling. If you just finished exhaling, there should be the pressure, there should be no pressure gradient. And so what if we have the pressures in here would be the same? Well, we already mentioned, or I had mentioned, that according to the law of Laplace, the pressure required to keep the alveoli open, this would be a distending pressure, this P, to keep the smaller alveoli open is greater than for the larger alveoli. So if, for example, the pressure that you had was just enough to keep this one open, it would not be enough to keep the smaller one open. So what's going to happen? The smaller alveoli will collapse, and as it collapses, the air is going to go from the smaller into the bigger alveoli, and you'd have alveolar collapse. So how can we prevent this from happening? Well, here's surfactant to the rescue. I have a large alveoli, I have a small alveoli. I've got the surfactant molecules lining the alveoli, and what you'll notice though is the larger alveoli, the surfactant molecules are further apart than here. We have the same number of surfactant molecules, but in the larger alveoli, they're further apart, so the surface tension is greater than in the smaller alveoli, because these guys are more closer to each other, which reduces surface tension even more than you see in the larger alveoli. Well, what you'll notice is if you look down here at the bottom, with having variable surface tensions, which is what we have, I am able to have the same distending pressures to keep both or two different size alveoli open. So surface tension of, or I should say, because of the presence of surfactant, you actually have variable surface tension. The larger alveoli, the surface tension is greater than the smaller. And so what it does is allow me to keep these two different size alveoli open because the distending pressures are the same between the low and the large, or the smaller and the larger alveoli. So what it's going to do is going to help prevent the small alveoli from collapsing, allowing us to maintain different size alveoli. So it makes it it increases, or say, the stability of the alveoli. I want you to think of it this way too. If I have, say, this, we'll start with this alveoli right here, and you increase the amount of air that's coming in the alveoli, you're inhaling, this alveoli is going to become bigger and bigger and bigger. You're not changing the number of surfactant molecules. So you're going from this to here as the air goes in. And so as you take larger breaths in, surface tension is going to start to increase, which does what? As surface tension goes up, it's going to start to reduce lung compliance. It was what we saw on that earlier curve when I say compliance changes during normal respiration. So you saw the slope of that line start to kind of flatten out because lung compliance starts to decrease at the higher lung volume. So besides stretching out the elastic element, the surface tension starts to increase because the distance in between the surfactant molecules is increased. So having the surfactant there allows us to have variable surface tension, which aids in maintaining different size alveoli, but also explains why at the higher lung volumes, compliance starts to diminish. It's going to be harder and harder to get more air into the lungs at the higher lung volumes. Now, so in summary, some of the stuff, and we're going to explain one more thing, is we're going to, surfactant decreases surface tension, which will decrease the elastic recoil, the tendency to kind of collapse the airways, therefore making your lungs more compliant. Because surfactant makes the lungs more compliant by decreasing surface tension. It decreases the work of breathing. It also allows us to maintain different sized alveoli. You could write that in. Allows us to have different sized alveoli, which should be just by itself, stabilizes alveoli. But what also it does is it helps to keep alveoli dry. So how does it keep are allowed to keep alveoli dry. Well, this surface tension would tend to suck fluid into alveoli, from the interstitial space into the alveoli. So if you have surfactant there with lower surface tension, you will have less tendency for that fluid to go into the alveoli. So we're going to, in a moment, we're going to be looking at condition that would perhaps diminish the amount of pulmonary surfactant and cause different things to happen in regards to the alveoli, how stable they are. Are the alveoli dry? What's the work of breathing involved? But what I want to first do is look at other things that help to keep the alveoli stabilized. The surfactant's a major one. It allows you to maintain different size alveoli. It keeps those smaller alveoli from collapsing. But you have interdependence of alveoli. So each of these represents an alveoli. And these each are attached to each other. So if this one in the middle is starting to collapse, it starts to pull on these. These are all connected. These guys will help to kind of keep them open. Another thing is you have fibrosepta. So here's all those alveoli. We'll say we take these, put them in here, but you have fibrosepta that kind of attaches to one set of alveoli. These guys, again, will try to keep these ones open, and then if these guys collapse, these will try to keep them open, therefore and therefore. So what happens is you have a lot of things in place to try to keep the alveoli from collapsing. You've got surfactant, the fact that they're all connected to each other, that you have these fibrosepta that kind of connects these things or keep them from collapsing. They're structurally connected to surrounding structures. These all things help to prevent the alveoli from collapsing. Doesn't mean it never happens, because it does, but we have things in place to try to prevent it from happening. But what about if I have a lack of surfactant? There's a thing called the respiratory distress of the newborn. You see these with premature babies. And if a baby is born too early, they will not be able to, they're not producing sufficient amount of surfactant. So they usually say about 35 weeks in gestation, it's usually adequate. So if the child was born prior to that, they may not have enough surfactant. Now, surfactant is absolutely necessary for survival of the newborn. So, and also, you can have what we call adult respiratory distress syndrome, which is associated with insufficient production of surfactant. Surfactant is continuously made in your lungs. There's a rapid turnover over it. So it's produced from fatty acids that are extracted from the blood, or they're also made, or from fatty acids actually produced in the lung. But if something happens that affects maybe blood flow to a certain area of the lung, maybe because you had an embolus or other conditions, the production of surfactant may be insufficient for an adult and lead to the same things that we see with the premature baby. Examples of adult respiratory distress syndrome could be from acid-base disorders like acidosis, pneumonia. You get impaired production with people with pneumonia. Drowning victims. Here's more of like a washout of surfactant with drowning victims. Hypoxia or even hyperoxia. Both of those, too much or too little oxygen, can cause adult respiratory distress syndrome. So what happens if you have a lack of surfactant? What's going to happen? So look at some of the things that can result from it. The lungs are stiffer because of low compliance. So remember, if you don't have enough surfactant, surface tension is high, lung compliance is low. So surfactant helps to keep the lungs compliant. Don't have enough surfactant, the lungs become stiffer. You're not going to be able to get as much air into your lungs. But also, you're going to have areas of collapse. Fancy term for that various areas of collapse would be something referred to as atelectasis. Because of the lack of surfactant, you can't maintain different size alveoli. And when you exhale, those water molecules again are attracted to each other. and the alveoli will collapse. It can also lead to pulmonary edema, where you get fluid accumulating in the interstitium, and then eventually goes right quickly into the alveoli. So that surface tension is much higher in these people. That's going to track the fluid into the alveoli, leading to edema, and that will impair gas exchange. So we're going to have problems with oxygen levels and CO2 levels, because one, I have problems with gas exchange, but I also have problems getting air into my lungs. And so with respiratory distress syndrome of the newborn, in adult respiratory distress syndrome, you can see all of these things because it's associated with that lack of surfactant. Now, a couple last topics that we're going to talk about before we look at spirometry, which allows us to measure lung volumes and capacities, is first I want to look at the effect of your thoracic cage on lung expansion and introduce you to your first lung volume or capacity, which is really where we look at a capacity, is remember the lungs and the chest wall move together, since the lungs are coupled to the chest wall by that molecular cohesion with the liquid layer of that pleural space. So remember, out here the thoracic wall is lined with that parietal pleura. The lungs are lined with visceral pleura, and remember they're connected to each other. Remember, the lungs are elastic. They always have a tendency to go in, collapse. The thoracic cavity or the thoracic wall is also elastic, and these guys always want to move out. If I had introduced say some air into this space right here, what would happen is I can get these guys to uncouple from each other. The lungs would collapse. The thoracic wall would actually move out. So, what's so important about this picture right now? Well, we're talking about normal situation. At the end of a normal expiration, you have the outward recoil of the chest wall is equal to the inward recoil of the alveoli. And what the volume that you have in the lungs is referred to as our functional residual capacity. And that is written out for you later in your notes or when you look at the lung volumes and capacities. But the volume that's in here is about 2,300 to maybe about 3,000 mils of air that you have in your lungs after a normal exhalation. So this is when, or I should say, that volume of air in the lungs at that point is because the elastic recoil of the chest wall is equal to the inward recoil of the alveoli. Well, what could be so important about knowing that? Well, conditions such as emphysema. If people with emphysema, they're losing their elastic element in their lungs. So after a normal exhalation, remember, they have a hard time for those lungs going back to the original volume. Here, what's going to happen, you don't have that as great of inward recoil of the alveoli. What's going to happen is the lung volume, or that capacity, is going to be bigger. People become barrel-chested. So this is going to be a little bit bigger out here. And you'll see that people with emphysema tend to be barrel-chested. The functional residual capacity is going to be a bigger number. And so that's going to be kind of an important thing to realize when you look at lung volumes capacities. Certain changes in lung volumes capacity are associated with certain lung disorders. And we have lung disorders that they classify as being restrictive lung disorders, and we have lung disorders referred to as obstructive lung disorders. And the different changes in lung volumes and capacities are associated with those separate examples of lung disorders. Now, the last topic before we look at those lung volumes and capacities is work of breathing, but I want to show you this picture in which we have something called pneumothorax. They've introduced, someone here got shot. You could have done this with a stab wound or something like that. Introduced air into that pleural space, and so you got uncoupling of the thoracic wall and the lungs. And what happens is the lung will collapse, the thoracic wall, I wish they had a picture to show it to you, the thoracic wall would move out. Now, generally, because these guys are in two separate cavities, just this lung should collapse. But if it's significant enough, you can get something called mediastinal shift, where this is bad enough, it would actually collapse the other side too. Now, the last here at the topic is looking at work of breathing. Just like when we talked about work associated with the heart, you had to move a certain volume of blood against a certain pressure. When we talk about the work of breathing, we have to move, or move certain volumes of air, and you have to generate certain pressures. Now, there are three major types of work associated with breathing, and we're going to look at the lungs. In the lungs, we have what we call compliance work, tissue resistance work, and airway resistance work. Now, compliance work, I put a star by it because this is requires the greatest amount during breathing. This is the most work that you have to do with normal breathing, is compliance work. So compliance work is the work that required to expand the elastic element of the lung. So at rest is your primary workload. Tissue resistance work is work to kind of move tissue. So you have, each tissue has some viscous forces associated with it. So you have to move or slide the tissue against each other. It's minimal at rest. Think of it as, since the tissue is mostly made up of water, it's kind of like moving water. But you got to move tissue. You got to overcome the viscosity of the tissue. Normally, not much of a problem. This may increase with conditions such as edema, also with fibrosis. That would be harder to move tissues. That would increase. You would also have an increase in compliance work, though, with things like fibrosis also, because you're going to have to expand the elastic element, and fibrotic tissue is harder to expand. It's going to want to stay in its original position. The other component of work is airway resistance work. It's the amount of work required to move air through the airways. It's very low at rest, but it will increase during exercise, because during exercise you're moving large volumes of air very, very fast. And so resistant work does increase during exercise. You could also have an increase in airway resistance work with things like chronic obstructive pulmonary disease. You have COPD. Emphysema is an example of something like that. That can increase their airway resistance work. Exercise is also an example that would increase compliance work too, because you're expanding the lungs even further. So exercise is not a bad thing. Just have to realize when you exercise, you're going to have to work more. Got to work more to move those lungs and get more air into and out of the lungs. Normally, the work of breathing is only about maybe 3 to 5% of the total energy used by your body. But certain conditions, like asthma, or more, this would be something that you see all the time, because people don't have asthma attacks 24 hours a day, is like emphysema. If someone has emphysema, their amount of work that they need to breathe is significant. And so normally at rest, we don't have to do a lot of work breathing, but these people have to work a lot to breathe just sitting there. Now, you also have work associated with the thorax, because remember, you have to expand and contract the thoracic cage too. But these are the ones I want you to kind of worry a little bit more about, knowing what compliance work is, what tissue resistance work is, and what airway resistance work is. Now we're going to take another break. So when we get back, we're going to go over pulmonary volumes and capacities, and this is something that you're going to be doing in lab.